Good afternoon, everybody. As Martin mentioned, I'm the director of the sleep service in St. Vincent's University Hospital, and we've been taken on and are very grateful to have been taken on as a virtual sleep lab. I suppose we're in the midst of a pandemic, as has been discussed, but we actually have a second pandemic that's affecting Ireland, which probably doesn't get highlighted as much. So in the next 5 years, 37% of Irish women will be obese and 38% of men will have a BMI above 30. And that has implications for my service, which is a sleep service, where the most common presentation that we have is a condition called obstructive sleep apnea. This is where people hold their breath. These are just two oximetry tracings from sleep studies. On top, you can see somebody who's a fairly level of oxygenation throughout the night. And below, you have a patient with severe obstructive sleep apnea. So they repetitively hold their breath, essentially choke themselves, and have this varying pattern of desaturation in their oxygen levels throughout the night. And this has implications day to day. They can feel quite tired and sleepy. Long term, this is cardiovascular implications. So it's not a benign process. It increases your risk of high blood pressure, heart attack, stroke, funny heart rhythm, multiple cardiovascular comorbidities. So sleep services are often linked with respiratory services because obstructive sleep apnea is a respiratory condition. Now, I think in St. James's Hospital, they've thankfully led the way and have established the National Narcolepsy Clinic, which is a welcome development to sleep services in Ireland. But apart from that, really sleep services have developed in a very ad hoc fashion. And the ad hoc development of these services has now met with increasing numbers of patients. Services are overwhelmed with admin associated with the care of these patients. We often can't discharge patients because there isn't the expertise in primary care to deal with it. And it's a very niche area in terms of specialty. We also lack trained staff. I'm not just talking about doctors, but I'm talking about physiologists who are trained in the assessment of these patients and with regard to the diagnostic sleep studies that we perform. And COVID did create a massive issue for us in that the use of CPAP therapy in hospital, which is the most common treatment that we use for obstructive sleep apnea. So that's continuous positive airway pressure. It's a little machine that sits in the bed, beside the bed, with a hose coming off it and a mask that a patient wears. So the machine drives air into the upper airway and keeps it cushioned open over the course of the night. That's actually an aerosol generating procedure. So that complicated our ability to deliver care throughout the pandemic. With regard to primary care actually invests a huge amount of money in this area because for patients with medical cards, the rental of the CPAP devices is funded through the medical card system. On top of that, if patients are using CPAP and are part of the drug refund scheme, they can also be reimbursed with regard to that. So the medical card patients cost, we estimate, so it is only an estimate, and it's a very conservative estimate, maybe out quite significantly with regard to this, but I think it's about 15 million a year. We don't know what the cost is with regard to the drug refund scheme patients. So 8-figure sums are being spent on an annual basis with regard to provision of treatment for these patients. And we don't have clear capture with regard to that spend. We're talking about a condition where 1 billion people on the planet are thought to have obstructive sleep apnea. And we don't, for something that is as prevalent as that, we don't have expertise within primary care at this moment in time. So we can't move this very readily to the primary care sector from hospitals for our GP colleagues to manage. We have CPAP providers who provide the devices to patients, and we don't have objective data on their service quality. Anecdotally, I think my experience is they provide a very high level of care to the patients. But they have quite advanced telemonitoring systems, which we're not actually using as well as we should. one of the big issues with regard to it is each provider often has a specific brand of device. So they're not all using the same types of device. And because it's not brand specific, in an already overwhelmed sleep service, it's very difficult to integrate that technology into the care system. So this results in a system where patients have long wait times. I've done virtual clinics in the past couple of months with public patients where they have been referred in 2017. So they've been waiting over 3 years for assessment. I'm currently seeing patients today who were referred in October 2018. So wait times to be assessed in our services are overwhelmed. And one of the problems is we can't really discharge patients. So if you take a category 2 driver, we're mandated by the Road Safety Authority to see those patients on an annual basis to ensure that they're asymptomatic and that they're using their CPAP devices and that their disease is adequately controlled. So we can't discharge patients who were there before. And in terms of accessing diagnostics, it's also difficult. My patients are waiting now over a year for their diagnostic sleep study. So that's a long lead time before they get seen. And after people have gone through that full process, we have a scenario where a lot of the time, after the patient has been commenced on treatment, that CPAP device is actually just left in under their bed. They don't actually use it. So there's a huge amount of waste within the system. So if you go to one of the telemonitoring systems, and I did this on Monday morning in anticipation of giving this talk today, and I've hidden the patient's names, but you can see clearly that this is St. Vincents Hospital, my name, I've accessed. There's a range of dates, anywhere from 4 years, 5 months. This patient has been on it. It's getting a little green mark. They're using it 5 hours, 4 minutes per night. It was last updated the day before. But then you see patients, we started 21 days ago, hasn't used the machine. This patient has been on it 45 days, not using it. There's variation. This patient has been on 1 year, is not using it. So the data is there on these devices, but we don't have a system of integration between these telemonitoring systems so we can act with regard to these patients. And actually 2/3 of the first 100 patients that I looked at, 63% were not using their device. So it's not all doom and gloom. You can use these telemonitoring technologies very, very efficiently. And this, again, is a case study from this week. So this is sleep services. I have said we deal mainly with obstructive sleep apnea, but this is actually a quadriplegic patient. So he's on non-invasive ventilation at night, because when you go to sleep, that's when people with neuromuscular weakness are most vulnerable, because your muscle tone drops during rapid eye movement sleep, and you're likely to not ventilate yourself very well. So this patient is on a ventilator at night to assist him when he's asleep. And you can see here, I've looked at a period of time up until the 6th of December, and he's feeling unwell, he's feeling lethargic, he feels that his ventilator isn't doing what it was doing for him. So he contacted the laboratory. And I can see here his AHI, which is a marker of the severity of obstructive sleep apnea. I can see that that's climbed. It's almost 12. So less than 5 is what we would have for normal. So this patient is having mild obstructive sleep apnea. And we were actually able to get remote oximetry on the patient, which confirmed that. And you can see desaturations in his oxygen level, and it's affecting him. This is his heart rate, and you can see there's a lot of heart rate variability as a result of these apneic episodes. So it's affecting him physiologically in terms of his cardiac response, and he was feeling unwell as a result of this. I have the ability to access that individual ventilator online, and I adjusted his pressure settings from 15/6 and was able to check 1 day later, see how he was getting on. He was on 17/8 instead, and I'd see that I managed to correct his AHI down to 3, gave him a phone call, and saw that he was actually feeling an awful lot better. So Martin has talked about staying left, shifting left. This is a case example of where we've managed to do that. We've managed to maintain this patient's quality of life, his quality of care. It was a low-cost intervention. The patient, who it's very cumbersome for him to come to hospital, involves bringing his care, difficult transport issues if he is come in for assessment. This was all done. And in terms of clinician experience, I didn't even do this on my laptop. I did this on my mobile phone. Once I knew what was needed to be done, I was able to track him on my mobile phone, and I was actually able to change and improve his care remotely. So George earlier, when he was speaking, he said that we know we have a problem and that we need to do something, but what is the correct thing to do? So we need to assess that and follow key messages with regard to that. And we need to clearly identify, we know there's a problem. It's clear there's a problem, that the system is broken and we have to fix it. But what are the things that we need to do? So what we need to do is we need to improve access for our patients. We need to improve the management pathway that we have and improve end-to-end care from these patients, because there's problems along all steps of the process. We need to reduce the clear waste. If we have a system where we're actually potentially wasting an 8-figure sum if 2/3 of patients with medical cards aren't using their devices, after a very complex process to get them onto the device in the first place, that is not giving good value for money. And we're faced with a worsening obesity pandemic where we're going to have to intervene with more and more patients. So we need to be able to pivot to actually deal with these increasing numbers. So if we're going to do something, we need to be able to monitor that intervention and see that we're improving things. So we need to be able to see that we're going to impact on waiting lists. I've given you an example where you can actually remove the need for an outpatient visit, and then remove a need for an outpatient visit in a patient who has complex care needs. We can, using a change in the system that increases the number of patients that can actually be seen. And we need to be able to remove tasks that don't need to be done by physiologists, by nurses. Tasks not only that shouldn't probably be done by a secretary, that you actually automate the processes with regard to this. We need to improve compliance with treatment, and where there is non-compliance, reduce the spend associated with that, because it's very significant. We're faced with an increasing challenge with obesity, but as Martin pointed out, he showed you the Sunrise app earlier, the Sunrise device for testing. There's other things in the pipeline. We've actually validated an algorithm, or helped validate an algorithm for Fitbit. Itamar have a WatchPat, which is an Israeli technology. So these are all things that are going to come into the Irish market, and we need to be in place to actually connect with these. So we also need to be able to give objective data to the HSE. So they're actually going to procure CPAP therapies, but get good value for money, and just make sure that we're getting quality providers. So what we have developed is a bespoke middleware solution. It's middleware. It sits in the middle between these existing telemonitoring systems and the healthcare system. It incorporates an electronic health record, and we have a survey tool built into this, which we can ask questions, anything in advance at any time, and time those surveys going out. It has a virtual consultation platform, and we already have integration with one of the CPAP monitoring systems with AirView, and agreement to integrate with ResMed or with Philips Respironics through Air Liquide. COVID has helped with regard to this, because these companies in industry have realized if we're not seeing our patients, they're not getting new clients. So they've worked with us with regard to this integration. We can automate the management of drivers, so that if a driver needs their license renewed and they're doing well on treatment, send them a survey and track their usage remotely, but don't bring them back to a clinic unnecessarily. We have very advanced monitoring systems in sleep, and I think this is a good template for chronic disease going forward. And the survey tool, we've also shown the ability to use that for COVID screening, and it looks like that's going to be taken on in another hospital. We've called this platform SUAN, because SUAN is the Irish for sleep. People might think Culla is the Irish for sleep, but SUAN is actually the Irish for the best kind of sleep, Culla SUAN. So it's a web-based platform. you know, this is the setup. When you access, you put in your practice name, hospital name, and your details. All patient medical records can be stored on it, so it works as an electronic health record. But if you want to send a questionnaire with regard to a patient, see how they're getting on, screen them for COVID symptoms, this is what it looks like when it comes to the patient's smartphone, and they can actually click into the questionnaire and answer whatever questions you want to ask. As I said, it's set up for a video consultation platform, so you can have your virtual clinic set up on the platform. But the key difference with regard to this is we can continue the monitoring in an agnostic fashion of patients. So it doesn't matter which CPAP provider the patient is with. Using APIs to the individual telemonitoring systems, we can access those and we can color code it. So at a glance, I can see that this patient is using his device 6 hours per night. His averaging number of events is less than 5, has a little bit of leak, but he's doing well. I can identify the patients that haven't used their device at all in grey. In orange, we can see those that have low usage, but are switching it on every so often. And when they do use it, are actually correcting their therapy. So there's room to work with it. But at a glance, irrespective of the company that is providing the treatment, we can now see this. And the aim is to do this across a number of CPAP providers. I think I heard the bell there a few minutes ago, so I'll leave it at that. But if there are any questions.
Thanks, John.
Thank you very much, John. I think we'll certainly look for questions, you know, on to be tracked here, and we'll forward them to you.
Okay. Thanks, Martin.
It's great to see the progress, and we're delighted to have the Digital Sleep Lab as part of the network of living labs. It's great.
We're delighted to be involved. Thanks, Martin. Thanks for all your support today.
No, great, and this is really exciting. And you know, what you've highlighted, the obesity problem, that's obviously something we need to collectively work on, or else, you know, what you've outlined will get a lot worse. Great.